Bismillahirrahmanirrahim. This video is about peripartum cardiomyopathy from the TOG article 2021. What is the definition of peripartum cardiomyopathy? The European Society of Cardiology defined peripartum cardiomyopathy as idiopathic cardiomyopathy presenting with a heart failure secondary to left ventricular systolic dysfunction toward the end of the pregnancy or up to 6 months following delivery with no other cause of the heart failure being diagnosed. So it is a diagnosis of exclusion. Now, the left ventricle may not be dilated, but the ejection fraction is nearly always reduced below 45% in such condition. The estimated incidence in the Western healthcare ranges from 1 in 1,000 to 4,000 pregnancies. What are the risk factors of peripartum cardiomyopathy? The disease more commonly manifests in women of Afro-Caribbean lineage and carries a poor prognosis. Other risk factors include multiparity, multiple pregnancy, obesity, chronic hypertension, preeclampsia, and advanced maternal age. So even though the disease can strike women of any age, those older than 30 years of the age are at higher risk. What is the pathophysiology of peripartum cardiomyopathy? The true pathophysiology is considered to be multifactorial. However, the recent attempts at exploring peripartum cardiomyopathy etiology have proposed a two-hit model of genetic predisposition combined with a vascular hormonal insult. So multiple genetic targets are associated with this condition. Many of these genes regulate the myocyte function with a mutation predisposing to peripartum cardiomyopathy. The transcription factor STAT3 becomes activated to a large extent within the normal heart during pregnancy and in the postpartum period. Now we will talk about the diagnostic approach for peripartum cardiomyopathy. The symptoms of the heart failure include dyspnea, orthopnea, paroxysmal nocturnal dyspnea, pedal edema, unexplained cough, particularly when lying down, dizziness, palpitation, fatigue, chest pain, and abdominal discomfort. So in the initial evaluation, first we need to take history from the patient about the known congenital or acquired heart disease or the family history of the ischemic or non-ischemic heart failure. In the physical examination, we try to find out whether there is tachypnea, tachycardia, peripheral edema, or JVP distension or not. On electrocardiogram, there is really no specific pattern of peripartum cardiomyopathy, but may rule out the ischemic or thrombotic causes of that. Among the blood tests, we do the hemoglobin, C-reactive protein, white cell count, natriuretic peptides, troponin T, and blood gases analysis if the patient is unstable. The echocardiography is crucial in diagnosing the peripartum cardiomyopathy, and we usually have the left ventricular ejection fraction of less than 45%, and ventricles may or may not be dilated in such condition. The other investigations include chest X-ray, cardiac MRI, and rarely endomyocardial biopsy. The ventricular arrhythmias are known to occur in 20% of the women with a peripartum cardiomyopathy. Among the differential diagnosis, first we have benign dyspnea of the pregnancy, which is usually gradual in onset, along with the mild breathlessness with no associated cough, normal heart pattern, and the oxygen saturation, and there is no JVP distension. So usually there is no investigation needed in such case, and the chest X-ray and ECG are usually normal. Another differential is that of the arrhythmias, in which we have palpitations followed by the acute heart failure presentation. In this condition, we have the tachyarrhythmia on ECG, pulmonary edema on the chest X-ray, diffuse hypokinesis typically seen on echocardiography. Another differential is that of the amniotic fluid embolism, which is sudden respiratory failure and circulatory collapse during or immediately after delivery. The blood tests show raised D-dimer schistocytes, low fibrinogen, and thrombocytopenia. Another differential is asthma. Patient usually gives the history of the asthma, wheezing, or decreased air entry on examination. The investigations include pulmonary function testing with a positive provocation test or response to the bronchodilator challenge. Another differential is that of the pre-existing implantable cardioverter defibrillator. These patients usually present by the end of the second trimester. So we need to take the detailed history, ECG, brain natriuretic peptide, echocardiography, and the cardiac MRI. Another differential is that of the HIV cardiomyopathy. In this condition, the patient presents with the non-dilated ventricles, and we need to take appropriate history and do HIV antibody testing. Sometimes the pre-existing valvular heart diseases are unmasked by the pregnancy, for example, rheumatic valve disease. These patients usually present by the end of the second trimester. So in such patients, we need to take appropriate history, do appropriate examination. ECG may show the chamber enlargement, chest X-ray show pulmonary edema plus left atrial and pulmonary artery enlargement in the mitral stenosis. Echocardiography show culprit valve lesion. In hypertensive heart disease, proteinuria may be present on urine analysis. Chest X-ray shows the pulmonary edema. Echocardiography shows preserved or mildly decreased left ventricular ejection fraction. There is left ventricular hypertrophy that may be present in case of the chronic hypertension. Another differential is that of the cardiac dysfunction secondary to the ischemia, for example, atherosclerosis, coronary dissection, vasospasm, or coronary embolism. Patients presents with the shortness of the breath followed by the acute heart failure. We need to do ECG, chest X-ray, and echo to reach to the diagnosis. Another differential is that of the pulmonary embolism. The patient presents with the sudden onset of the shortness of the breath along with the pleuritic chest pain. We need to do ECG, chest X-ray, VP scan, and the CTPA. Now, another serious complication is the risk of developing intracardiac thrombus, particularly when the left ventricular ejection fraction is less than 35%. Now, how would we do the investigation of a case of peripartum cardiomyopathy? Peripartum cardiomyopathy is often a diagnosis of exclusion. In this regard, a detailed investigation for the other cardiac and non-cardiac causes of the heart failure should be undertaken. Now, electrocardiogram is advised in any pregnant woman who presents with unexplained or new onset cardiac symptoms. The common symptoms include sinus tachycardia with a nonspecific ST segment and T-wave abnormalities. The different laboratory tests include C-reactive protein, the leukocyte counts, the hemoglobin level, which is frequently decreased, brain natriuretic peptide, that is BNP, or N-terminal pro-BNP. The cardiac enzyme TOG, a marker for cardiac myocyte injury, is often in the normal range in these women. Now, how to do the acute management of the peripartum cardiomyopathy? When patients present with the shortness of the breath toward the end of the pregnancy, we check the natriuretic peptides, those are BNP or pro-BNP, and the echocardiography. If we have raised BNP or pro-BNP and less than 45% of the ejection fraction, we need to involve the cardiologist. In such case, we need to consider the peripartum cardiomyopathy and other cardiovascular differential diagnosis. On the other hand, if we have the normal BNP, pro-BNP, or ejection fraction of more than 45%, then peripartum cardiomyopathy is unlikely, and we need to consider the non-cardiovascular causes. Although the chest X-ray is non-specific for peripartum cardiomyopathy, it may show typical features of the cardiac strain, such as the alveolar shadowing, the septal lines, the cardiomegaly, pulmonary edema, or pleural effusion. The most helpful tool among all the investigation for peripartum cardiomyopathy is that of the echocardiography, which usually shows the left ventricular ejection fraction below 45%. The left ventricular end diastolic diameter of more than 6 cm and left ventricular ejection fraction of less than 30% are indicative of a decreased prospect of the spontaneous recovery and an increased likelihood of mechanical support, transplant, and the death. Cardiac MRI is also a very useful tool for cardiac imaging. The cardiac MRI evaluates the features of the cardiac tissue injury such as the intracellular and interstitial injury, hyperemia, capillary leakage, necrosis, and fibrosis. The endomyocardial biopsy is rarely performed to exclude the other causes of left ventricular dysfunction, particularly when there is a diagnostic uncertainty. Now, the management of peripartum cardiomyopathy, which include a planned interdisciplinary, patient-centered approach, optimal medical therapy, and rarely mechanical augmentation of both circulation and ventilation. When the acute heart failure is diagnosed in the pregnancy, we need to confirm diagnosis by doing ECG, the blood tests such as the natriuretic peptides, the chest X-ray, and echo. Consider antenatal corticosteroids for the fetal lung maturation between 23 to 23 plus 6 weeks of gestation, along with a transfer to tertiary center. Next come the MDT meeting with a group of the doctors. Assess the heart failure severity when the systolic blood pressure is less than 90 millimeter of mercury, heart rate is more than 130 millimeter of mercury, respiratory rate of more than 25, oxygen saturation less than 90%, lactate more than 2 millimole per liter, and we have the altered mental state of the patient. Patient may present with a severe acute heart failure or the cardiogenic shock. So the immediate management include maintaining of the optimal preload, optimize oxygenation, add inotropes or vasopressor, urgent delivery, consider bromocriptine, and consider mechanical circulatory support, and check whether the recovery is there or not. In the antepartum period, involve MDT. And in case of deteriorating maternal condition, recommend delivery and advanced acute heart failure therapy. In case of the stable maternal condition, the heart failure therapy include hydralazine, nitrates, beta blockers, and diuretics. The postpartum heart failure therapy include ACE inhibitors, beta blocker, MR antagonist, and diuretics. And we have to consider the bromocriptine as well. After recovery, we consider the need for the transplantation or the weaning. In the heart failure therapy, when we consider diuretics, we go for delivery planning, MDT approach, and vaginal route is preferred in such case. In case of the advanced acute heart failure therapy, or when we consider the bromocriptine, after that we consider variable cardioverter defibrillator if left ventricular ejection fraction is less than 35%. And we continue the heart failure therapy. Now, the mainstay of the pharmacological management of peripartum cardiomyopathy is broadly the same as that for the generalized heart failure. It broadly splits into 4 groups. First of all, the pregnant and hemodynamically stable patients, the postpartum and the breastfeeding patients, and those who are hemodynamically stable. The postpartum and not breastfeeding patients, and those patients who are hemodynamically unstable. So how to manage all these groups of patients? Coming to the first group, in which we have a pregnant woman who is hemodynamically stable. So advise the salt restriction as an important first measure. A loop diuretic such as furosemide is considered because there is pedal edema. The beta blockers can safely be initiated. Anticoagulants like low molecular weight heparins, if needed, should be given. Antiarrhythmics such as adenosine, verapamil can be used in these patients. How to manage the patients who are in postpartum stage? They are breastfeeding and hemodynamically stable. Several ACE inhibitors and angiotensin receptor blockers are compatible with the breastfeeding. Beta blocker therapy can be continued, as can hydralazine and nitrate therapy. Low molecular weight heparin can be continued if needed, but the warfarin is also compatible with the breastfeeding. How to manage patients who are in postpartum phase and are not breastfeeding? Within this cohort, all pharmacological options are open to the clinicians, including ARNI, SGLT2, and DOAC. How to manage the hemodynamically unstable patients? These patients need rapid and aggressive therapy, usually requiring admission to the intensive care units. The initial therapy is centered around the principles of optimization of preload, which can be achieved by administering the intravenous diuretics, particularly when there are signs of congestion such as pulmonary edema. Adequate oxygenation should be maintained in the optimal range of the oxygen saturation of more than 95%, and where possible, the patient's thorax should be kept upright. The circulatory support with inotropic and vasopressor therapy is provided to the patient. Urgent delivery is indicated if heart failure occurs during pregnancy. Ideally, when feasible, patients with a severe manifestation of the disease should be transferred to and treated in an experienced tertiary care unit. Among the drugs used for the heart failure, the beta blockers are safe both in pregnancy and in lactation, and we can continue it for at least 12 months. The ACE inhibitors are teratogenic, so avoid in pregnancy. During lactation, enalapril and captopril can be continued because of the low transfer. We can continue this therapy for at least 12 months. The angiotensin receptor blockers are teratogenic, so avoid these in pregnancy, and also these are not safe in the lactation as well. So recommend for the woman who cannot tolerate the ACE inhibitors, and we can continue it for at least 12 months. The mineralocorticoid receptor antagonists are best avoided in the pregnancy and also in the lactation. So recommend for all the patients with the left ventricular ejection fraction of less than 40% only, and continue for at least 6 months. The diuretics are avoided in the pregnancy because of decreased placental blood flow, but we can continue them during lactation period. So, continue only when the symptom control is needed for edema and congestion, and discontinue as soon as the symptom control for the edema and congestion is achieved. The vasodilators may precipitate the uterine hypotension, but these are safe in the lactation, so continue only when the symptom relief is needed, but discontinue when asymptomatic. The use of the bromocriptine, a dopamine D2 agonist, within this cohort of the patient is increasing. However, American Society of Cardiology classed its use as an experimental. If it is started, we need to start the low molecular weight heparin along with it as well. Next comes the role of mechanical circulatory support. When inotropic support fail, then comes the role of mechanical circulatory support. The ventricular support devices include intra-aortic balloon pump and intraventricular pump, for example, Impella. Now we will talk about the advanced heart failure therapy. Nowadays, the optimal medical therapy is preferred, avoiding the implantation where possible. The American Cardiology and the Heart Association recommend the consideration of these devices in severely impaired peripartum cardiomyopathy as a bridge to ejection fraction recovery, or if needed, to the full intracardiac device implantation after 3 to 6 months. Now, the checklist for the management of acute heart failure caused by the peripartum cardiomyopathy include, first of all, the multidisciplinary approach, avoidance of the heart failure drugs with the teratogenic risks during pregnancy and breastfeeding, the anticoagulations with the low molecular weight heparin, especially in the woman with a left ventricular ejection fraction of less than 35%, and in the case of the cardiogenic shock, consideration of levosimendan of 0.1 mg per kg per minute for 24 hours instead of the catecholamine as a first-line inotropic drug, and the early transfer to the specialist care center with the evaluation for the mechanical circulatory support where necessary. If the fetus needs to be delivered prematurely, intramuscular corticosteroids are administered between 24 weeks of gestation and 35 weeks plus 6 days of gestation to promote the lung maturation. Now, optimal intrapartum care is provided in accordance with a NICE guideline about the intrapartum care management, in which we do 32 hourly monitoring of the fluid balance with a 4-hourly assessment by the senior clinician. But nowadays, the WHO labor care guide is preferred. However, in the cardiac patients, we need to do the vigilant monitoring of the blood pressure, pulse, respiratory rate, oxygen saturation, as compared to the normal patients who come under the care of WHO labor care guide. In the third stage of the labor, slow infusion of the oxytocin is the first-line recommended drug to avoid sudden hemodynamic change. Misoprostol and carboprost FG F2 alpha are used as second-line treatment to reduce the risk of the hemorrhage. Regarding the breastfeeding, it is written in the TOG article that since prolactin has been associated with causing peripartum cardiomyopathy, it would be a reasonable argument to avoid the breastfeeding altogether. Regarding prognosis, it is written that around 50 to 80% of the women diagnosed with a peripartum cardiomyopathy achieve recovery in their left ventricular function, mostly within the 6 months after manifesting the disease. In the subsequent pregnancy, in the woman with a persistent left ventricular ejection fraction, there is 50% chance of further deterioration in the left ventricular function and increased morbidity and mortality rate in the coming pregnancies. So for the management in subsequent pregnancy, the best advice is preconceptional counseling with a multidisciplinary team of experts, including cardiologists, obstetricians, and physicians with an interest in the maternal medicines and fetal and maternal anesthetist, neonatologist, and other allied specialties. Regarding the contraception, it's written that intrauterine devices such as the copper and progesterone-releasing IUDs are not just effective and long-lasting, but also have no added risk of thromboembolism. Now, here we have recommended schedule of screening echocardiography for the woman with a history of peripartum cardiomyopathy. and that include the preconception period, the end of the first trimester, end of the second trimester, 1 month before delivery and 1 month after delivery. So thank you so much. That was all about peripartum cardiomyopathy. TOG article. Subscribe on Obstetrics and Gynaecology. Allah Hafiz.